When we perform an echo exam, we should go about in a standard fashion. We should always use the same sequence, and the first window we use is the parasternal window. The parasternal window is located on the left of the sternum, and we use the intercostal spaces, either the second, third, or fourth intercostal space, depending on the axis of the heart. How do we find the parasternal window? Well, the patient is in a left lateral position. We try to bring him over as far as possible. Then we take the transducer and we have the thumb on the marker. And the marker is oriented towards the right shoulder. And then we put the transducer on the chest and try to be as close as possible to the sternum. And then we just move downwards from one intercostal space to the next. And then we immediately see where the window is. Important to know that the parasternal window does not work in all patients, but usually you get image quality, I would say, probably in the 2/3 of patients. Always bring the patient in a very lateral position and try to stay as close to the sternum with your transducer as possible. The first view that we can get from the parasternal window is the parasternal long axis. What will we see? We will see a view that cuts the heart in a longitudinal direction, and thereby we get a view where we have the left ventricle visible, the right ventricle, the aorta, the left atrium, the posterior mitral valve leaflet, and the anterior mitral valve leaflet, as well as the aortic valve. So this is cranial, the aorta here, and this is caudal, the apex here. To find the parasternal long axis, it is important to understand the axis of the heart. If we look at the heart, it is oriented from a right upper to a left lower position, somewhere like my hand is showing now. If you want to orient the long axis, you therefore need to point the marker of the transducer towards the right shoulder. Again, I'll show you the parasternal long axis view, and you can see nicely how the pointer is actually oriented towards the right shoulder, or in his case, somewhere in the region of the clavicula. Now, what do we see in the parasternal long axis? This here is the right ventricle, the interventricular septum, the basal parts. This here is the moderator band. We have the left ventricle, we have the posterolateral wall, we have the LVOT, the outflow tract. This here is the aortic valve, the aortic root, the aorta, the ascending aorta. This is the left atrium. This is the descending aorta, which we hit orthogonally. This is the coronary sinus. And here we have the anterior and the posterior mitral valve leaflet, and also the papillary muscle. Just an example again. Classic parasternal long axis view. The aortic valve opening and closing nicely. The septum, the left ventricle, the right ventricle. Here the posterior wall, the left atrium, and this here is the aorta. What is the parasternal long axis good for? It's good to assess left ventricular function and size, even though we do not see the entire heart and we do not see the apex. We have a very nice view to the left ventricular outflow tract. Thereby we can detect obstruction or abnormalities of flow. Furthermore, the left atrium is visible, so we can assess the size of the left atrium. We also have partial view to the right ventricle, so information about the right ventricle is also possible. And very important, this is the view where we can assess the aortic root and also the ascending aorta. The ascending aorta is visible in the parasternal long axis view, but if you want to see more of the aorta, it's sometimes better to move the transducer up one intercostal space, and thereby you see more of the ascending aorta. This is very important, and we'll talk about that more in detail when we describe patients with problems of the ascending aorta. What else can we see in the peristernal long axis view, or what can we assess? The mitral valve, we're very close from the transducer to the mitral valve, so we get a very good image quality, and this is the classic view where we can diagnose, for example, mitral stenosis. We can also see problems associated with mitral regurgitation, such as Flay leaflets. The aortic valve is also nicely visible. For example, the motion of the aortic valve, if opening is normal, and what the degree of calcification is. Let's turn to a different long axis view, the so-called right peristernal long axis view, where we image the right portions of the heart in a longitudinal fashion, where we have the right ventricle here and the right atrium here. What is the difference between the right peristernal long axis view and the view we've seen previously, the peristernal long axis view? Well, here we tilt the transducer more cranially towards the left heart, and here we tilt the transducer more downwards towards the right ventricle. Let's take a look. The long axis right peristernal view is a very important view because you can assess the tricuspid valve very nicely. How do we get to the long axis view? Well, we start out from a classical long axis view of the left ventricle, and all we have to do is we have to tilt the transducer downwards. See, I'll be doing this right now. It's this motion. And by doing so, what we get is the right ventricle and the right atrium and the tricuspid valve. And we know that this here must be the anterior leaflet. The orientation of this view is variable. In most instances, it would be more horizontal. In his case, because he's such a slim person, the orientation is more horizontal, more vertical. So this would be the peristernal long axis view. Oh yeah, something I forgot to say. There's also the possibility to visualize the coronary sinus and also the vena cava inferior. Those are the structures that you see down here. From the long axis views, let's now turn to the short axis views. We can perform several different short axis views, but let's first start with the short axis view at the base. The peristernal short axis is in a 90-degree orientation to the long axis. So if you remember how we had the long axis, the marker was pointing towards the right shoulder. Now what we have to do is we have to rotate the transducer clockwise until we are perpendicular to the original plane. Now the marker, which is here where my finger is pointing towards the left shoulder, or armpit actually. We can cut the short axis at different levels. This would be the level of the basis of the heart, where we can see the aortic valve. We can see, this is the aortic valve, we can see the left atrium, in this case with the left atrial appendage, the interatrial septum, the right atrium, the tricuspid valve, the right ventricle, and the right ventricular outflow tract with the pulmonic valve. We can also see certain details. For example, here it is possible to even see the origin of the right coronary artery. The left coronary artery is more difficult to visualize in a short axis view. It would be somewhere down here. In summary, we get a view where we have the aorta at the center, and surrounded by the aorta we have the left atrium, the interatrial septum, the right atrium, the right ventricular outflow tract, the pulmonary valve, the pulmonary artery, and then the right and the left pulmonary artery. So we're cutting the heart right at its base through the great vessels with the aorta at the center of the image. What is the peristernal short axis view good for?
It's the view where we can assess the opening and closure of the aortic valve very nicely. We can see the three cusps of the aortic valve nicely here, and we can determine if the opening excursions are normal or not. Furthermore, we have the potential to see atrial septal defects here in the region of the interatrial septum. We also see the tricuspid valve, thereby we can look at tricuspid regurgitation. And we're very close to the right ventricular outflow tract, so we can look at pathologies which are located in this region as well. For example, if you have RVOT obstruction. Starting from a short axis view at the base of the heart, we can look at the pulmonary artery in a better fashion if we turn and rotate the transducer, so we get a long axis view of the right pulmonary artery. Let's take a look at such a view. This is the aorta again at the center. We have the pulmonary artery here with the bifurcation, right pulmonary artery and left pulmonary artery, and the pulmonic valve. How do we get to that view? We have to position the patient in an even further lateral position, and we have to tilt the transducer towards the left shoulder and also move the transducer more ventrally. What is this view good for? It's good to assess right ventricular obstruction. We talked about that earlier. But also to look at the size of the pulmonary artery, which is important in special clinical situations. Furthermore, we can see a patent ductus arteriosus. We'll be talking about that when we talk about congenital heart defects. Very important, this is also the view where we get the best images of the pulmonary artery. Thereby we can assess pulmonary stenosis and pulmonic regurgitation as we see it here in this image. Let's now turn to another short axis view. Let's turn to the short axis view of the left ventricle. There are several different views we can look at, starting from views which transect the left ventricle at the level of the mitral valve, have mid-ventricle, and more apically.
So how do I get from the short axis view at the base of the heart to the remaining short axis views? First, let's go back to the short axis view of the aorta. I would now tilt the transducer more apically, but still stay in a perpendicular orientation to the original long axis of the left ventricle. So the original long axis is oriented in this direction. I would now tilt the transducer exactly perpendicular. When I tilt the transducer, I will gradually lose the aortic valve, but I will see a new structure appearing. The structure down here is the inferior vena cava. Finally, I would arise at the mitral valve, and the mitral valve would then be the structure you see here with the anterior leaflet, the posterior leaflet. This is the LVOT, the outflow tract, and this would be the septum. If I tilt further down, I would leave the mitral valve, but I would still see structures, but these structures are not the valve, but they are the tendinae which are attached to the papillary muscles. So all these little structures here. Then I would move further down, and all of a sudden I would see the papillary muscles. Those are these structures here. And I would also see the right ventricle with the moderator band right up here. Okay, this is the moderator band. And if I want to go even further apically, I will have a problem because I will have to tilt the transducer even more, and I will then lose contact to the skin. So there's a little trick you can use. All you have to do is just move down one intercostal space, and all of a sudden you get a nice view of the more apical segments of the left ventricle. And you can even go down another intercostal space and get the supraapical regions, at least in some patients.
In summary, short axis view right at the level of the mitral valve, with the mitral valve here in the center. This is the left ventricular outflow tract, the septum, and the right ventricle. What is this view good for? Mitral valve stenosis can be assessed here. We can even perform planimetry to determine what the opening area of the mitral valve is in this clinical situation. And we also have a potential to look at mitral regurgitation and to see where the regurgitation originates, in other words, where the location of the defect is. Depending on where we cut the left ventricle in short axis view, if it's more cranially or more caudally, we can get different views. Either we still have structures of the subvalvular apparatus in our view, or if we have the papillary muscle. In both instances, we have the septum visible and also the right ventricle. What are these views good for? They're basically good to assess global and regional left ventricular function. In addition, we can look at the thickness of the septum and the motion of the septum, which is also important in medical clinical situations. Importantly, we also see the right ventricle. Thereby, we can have a way of looking at the size of the right ventricle and estimating if the size is normal or not. And furthermore, the pericardium is also visible so that we can detect pericardial effusions. A view that I also would like to show you, which I think is very important, is the peristernal short axis view, which is very, very apical, where we cut just the last portions of the heart. This view is sometimes even better to achieve if we use an apical position. This is the image that we would get. You see that we only see a very small cavity of the left ventricle. That's because we're at the very tip of the heart, and we have only very small portions of the right ventricle visible here. This view can be used also to assess regional wall motion abnormalities, especially if we have very supraapical infarcts. Ventricular function, of course, can also be looked at here, and thrombi, which are located at the very tip of the apex. Just to demonstrate the different levels of short axis views, this is the short axis view at the base with the aorta. This is the short axis view at the level of the mitral valve. Further down, where we have the papillary muscles visible, and even further down where we have the supraapical parts of the left ventricle within our view. So this was the peristernal window, but now let's take a look at another window which is very important, and a window which should be formed right after we perform the peristernal window, the apical window.